Hello and welcome back to CCRN Review. This is the neuro section. The neurological section is part of the musculoskeletal, neurological, and psychosocial areas, which makes up a total of 14% of the exam. So each one of those is going to take part of that 14%. In other words, there aren't going to be a huge number of questions on the exam on neuro, but there will be some. So we want to make sure that you're ready for those. The first section on the exam is talking about dementia versus delirium. Dementia is structural, it's chronic, irreversible, so this is something that is happening long-term to the brain that is going to cause a long-term change in mental status, whereas delirium is an acute metabolic situation. So let's take a look at a difference here. A patient comes into the emergency department, maybe has a history of dementia, yet the family is saying, well, this is not his normal state. Normally, he's a lot more alert than this. Normally, his memory is a little bit better than this. And now suddenly today, it's considerably different. Well, it'll be easy to just pass that off as dementia that is getting worse. However, we have to rule out all of those things that are delirium. So take a look at all of those metabolic pieces and make sure that it's none of those things before we go back and say, hey, this is just dementia. So delirium is caused by sepsis, myocardial infarction, and in fact, in most patients, older patients who come to the hospital with a change in mental status, we have to rule out infection, specifically urinary tract infection or pneumonia, and we have to rule out the possibility of hypoglycemia or electrolyte imbalances. One of the other components in the neuro section is the area of bleeds. So let's talk a little bit about the different types of bleeding, intracranial bleeding that can occur. First of all is a subdural. A subdural is broken down into three different categories. Subdurals are typically venous. So depending upon the size of the vein will depend upon what kind of symptoms we see. If it's a very large vein, we end up with an acute subdural, and we'll see symptoms within the first 48 hours. So this would be your patient who slips, falls on the ice, hits their head, and develops a subdural. That's an acute subdural. However, we can also have a subacute subdural. And in these situations, somewhere between 2 days and 2 weeks, the patient starts having symptoms. So again, the patient may have slipped, fell on the ice, hit his head. We don't really see any symptoms, and the patient may even have a negative CT scan because this is a slow, smaller bleeder that's occurring over a period of time. Chronic subdurals, we're going to see symptoms over a period of more than 2 weeks. So when they do a CT scan, we're going to see old blood there. Typically, chronic subdurals happen in the elderly. It happens over a long period of time, and there may not be any change in mental status because we've accommodated for this chronic subdural over that period of time. Epidurals are usually arterial in nature. The typical presentation is a loss of consciousness, followed by a lucid period, followed again by a secondary loss of consciousness. Now that is an unusual presentation. People who lose consciousness and regain consciousness usually stay there. So that secondary loss of consciousness, now you could say, well, couldn't that just be due to cerebral swelling? Yes, it could be. Okay, so that's something we'd have to rule out. But we're going to be looking for these in the areas where epidurals typically occur. So trauma to the temporal region, that's going to be a kind of a key sign here that this could be an epidural. So we see that trauma to the temporal area. The patient has lost consciousness at the time of the injury, regained consciousness. Be careful because this could be an epidural. Now again, because they are arterial, they will tend to form faster and under higher pressure than our subdurals and some of our other bleeds. Subarachnoid bleed, that's happening under the arachnoid membrane, and this is usually the result of an aneurysm. We can also have intracerebral bleeding, and that's happening within the brain tissue itself. Slowly developing, usually because there's small vessels. We'll see a progressive decrease in level of consciousness. These are associated with a poor prognosis because we can't remove them. So subdural is encapsulated. It's, between the dura and the skull, so we can pull it out. Epidural, we can still pull it out. It's encapsulated. So these are the types of bleeds that we could just make a burr hole, or we could take them to the patient's surgery and we can remove that blood. But in an intracerebral bleed, where we have bleeding directly into the brain tissue, we can't remove that. So it can be associated with a very poor prognosis. So here's some of the different types of bleeds, and you see where they're positioned. This is the epidural. Notice again, it's in the temporal region. So it's between the skull and the dura. Okay, so we've got that well encapsulated type of a bleed. But unfortunately, this is also usually arterial. Then we have the subdural. Now, the subdural looks a lot like the epidural did in this picture. However, it's below the dura, but above the arachnoid membrane. Now we have the intracerebral hematoma, and you notice that is all the way down into the brain tissue. So here's the different spaces here that are shown at the top part of the screen, and you can see the subarachnoid would be just below the arachnoid membrane, but above the pia. Concussion is another brain injury that the AACN wants us to know a little bit about. It happens with mild to moderate head trauma. So a concussion occurs, a patient will have a temporary loss of consciousness. They may have immediate neurologic symptoms such as confusion, nausea, vomiting, headache, maybe even some numbness, tingling, and things like that. But they're going to have some immediate neurologic symptoms. The temporary loss of consciousness and the neurologic symptoms will tend to dissipate over time. What happens is that there is some injury to the neurons themselves, which can then lead to the patient developing a post-concussive syndrome, where the patient maybe has some memory losses or they have some photophobia. There's some type of neurologic symptoms that continue on well after the concussion. So this is just showing what happens here with the axon shear as a result of having an injury to the skull. So when we have concussions, we can have a little bit of this injury occurring. Maybe not to the point where we're actually shearing our axons, but we're stretching them, we're hitting them, we're having some trauma to them. And that's what's causing the dysfunction neurologically for our patient. So symptom-wise, temporary loss of consciousness, the headache, confusion, disorientation, etc. We're going to go on the history, the clinical findings, and then CT scan to rule out any other pathology. So we're going to try and rule out any bleeds, etc. Post-concussive syndrome, again, as I mentioned, it can last for days to months. Repeated concussions, that's where we're really going to get into a lot of problems. We've heard a lot of this about this from our football players who have the repeated concussions over time, and they end up having a lot of neurologic dysfunction and maybe even go into early dementia or possibly death at an early age. Spinal cord injuries fall under the neurologic category as well. Typically, we're going to see these with motor vehicle accidents. The etiology is on the rise. Injuries in our patients who are greater than 60 years old, injuries from falls, and injuries to minorities are increasing in number dramatically. Now, when you take a look at the spinal cord itself and where it's positioned, you'll see that it is positioned in a place to have a lot of protection. So we have the disc that is on the front side of the spinal cord here, and the disc and the bony part of the spine is protecting that cord. On the back side there, you can see that we have bone protecting the back side of the cord as well. So the cord itself is really pretty well protected. However, if we have significant trauma, we can have fractures. So it's not just a matter of actually tearing the cord or having injury directly to the cord, but even just an injury to the bony pieces can cause the cord to be ruptured. So those sharp bony edges can cut the cord. We can have those nerves that are coming out. So you see the nerves coming out at the sides there, the yellow, illustrated in yellow. The nerves coming out to the sides that are innervating the body. Those nerves can be pinched. between the bones or by the disc, and then the patient can have symptoms. Two types of injuries here with the neck that we're going to talk about first of all is the hyperflexion injury and then the hyperextension injury. So the hyperflexion injury here, now we've got not only the movement of the neck in a position it's not supposed to be, but you also get this fulcrum. So you notice that the chin hits the chest and you get kind of a fulcrum that's occurring there from the chin hitting the chest. The head is still moving forward, and so it creates an additional tension on the cord in that hyperflexion injury. So we have distortion of the cord there, and in this case here, it's showing an anterior dislocation of C5. That doesn't necessarily have to happen in order to have that cord be torn or injured. Hyperextension is the opposite situation. So now the head is going back. Now we're not getting that same kind of fulcrum type of an injury. However, though, because in this situation it's showing that the patient's hitting their chin, the chin is going to have more mobility than the neck is going to, and so it can tend to push the spinal cord back even further. So now we're getting some compression here of the disc and of the cord, and that can cause the patient to have disability as well. A compression injury, and this could happen in the neck as well. Okay, so it's showing it here in the lumbar area. The two areas of the spine that are most likely to be injured is the lumbar spine and the cervical spine. And the reason for this is because there's nothing other than musculature that is protecting it. We get down in the sacral spine and we've got the pelvis protecting it. We get up into the thoracic spine and there's ribs and sternum, etc., that are protecting the thoracic spine. However, the lumbar spine and the cervical spine are left pretty unprotected. They just have to be able to manage on their own. Here we're seeing a compression fracture, so you see the compression of that vertebrae, and it's not only being compressed downward, but it's bulging outward, and as it bulges outward, it's going to bulge into that spinal cord. So this is the kind of thing that as it heals, the spine may, in fact, start to heal up and we have normal function again. On the other hand, we could also have some of those bony fragments that are sharp and they could lacerate that spinal cord, leading to permanent injury. A rotational injury, and oftentimes these rotational injuries are also associated with an additional injury. So, for example, rotation and flexion, rotation and extension. So in those kind of injuries, maybe the patient falls from a height, lands on the side of their head, and so now we've got rotation and hyperextension. So in those situations, we're going to have more injury occur because now we've moved that vertebrae out of a normal position where it's going to be strong into a position where it's not as strong. Gunshot wounds, okay, so we can have other types of trauma other than just blunt trauma and hyperextension and hyperflexion injuries. We could also have penetrating trauma that's occurring to the vertebrae. So, and again, it depends on where it hits as to what kind of injuries we're going to see. This is the shotgun injury to the pelvic area. So you can see here the lumbar spine, the sacral spine is going to be drastically affected by all these little pellets that are in the spine. Now, hopefully those are stuck in the discs and the bony structures and they did not get to the spinal cord. But if one of those does, it could very easily sever the cord or interfere with the cord's function. Fractures. As we have talked about some of the fractures before, we could have a simple fracture. In most cases, those are just stable fractures. They don't cause any kind of neural compromise. Obviously, there'd be pain, but they'd be managed conservatively, probably not put into any kind of immobilization. We probably wouldn't even send the patient to surgery to have that fused. So if it's unstable, then obviously it's going to need surgery. Wedge fractures, that's where the anterior vertebrae is compressed on the front side, and of course we can end up also compressing the disc at the same time. A burst fracture is a compressive force that occurs with trauma that's coming from the top. So, you know, it's that kind of compression fracture, but it bursts outward. It may also burst the discs, likely to burst the discs at the same time. Lap belt fracture. This happens because we have both twisting and pulling at the same time, and this is also called a chance fracture. Typically happens at the lumbar spine. High cervical fractures, this is an area to be concerned with because the high cervical fractures, as we get really high up there, we're going to run into problems with the patient being able to breathe on their own. So there's a high degree of mobility. The C1, C2 is responsible for 50% of the head movement. So there's a high degree of mobility up there in C1 and C2. C1 is rare. Okay, it's usually associated with a basal fracture of the skull, and usually is going to be fatal. I mean, there's not a lot we can do with that to try and rebuild that or immobilize it. C2 is common in the elderly, okay, and it will require surgical stabilization because, again, we're really concerned about having any kind of impingement on the spinal cord at C2. We'll lose our innervation of the respiratory tract. Not usually associated with neurodeficits, though, but it does require surgical stabilization so that it does not move or little fragments don't move and get in the way of the spinal cord. There's the whiplash injury. So the whiplash, we have that, first of all, the car stops, so the head keeps going and the head goes forward. We get that injury, the hyperflexion injury, and then the head whips back again, and we get that hyperextension injury. Same kind of thing can happen from being hit by behind. Is if the car was hit from behind, we'd have the hyperextension first, and then the head would whip back into the forward position and the hyperflexion. So we're getting both injuries occurring to the cervical spine at the same time. Oftentimes, this just causes some injury to the muscles and to the ligaments, but it can also cause bony injury as well. So there's two types of spinal cord injury. We're talking about a primary injury. So we have some kind of impingement from the bony fragments or from a foreign object that's impinging upon the spinal cord itself. We also have secondary. This can be the result of swelling. So we may have a fracture, and the fracture itself is not impinging on the spinal cord. However, the swelling and inflammation from the fracture is causing impingement on the spinal cord. This is worsened by hypoxia and by hypotension. Okay, so again, your multiple trauma patient, you may see that they have some neurodeficits on admission, but those neurodeficits may start to fade over time because we've resolved the hypoxemia and the hypotension. So some types of spinal cord injury, we have concussion. So that's like a concussion of the brain. We're going to have a temporary dysfunction for about 24 to 48 hours, and then it's going to start to resolve. That concussion may not completely resolve within that period of time, and there may still be some deficits, for example, maybe some numbness in an area or something like that, that may continue after that concussion. But we're seeing a resolution of the dysfunction over a period of time. A contusion, that's a bruising of the cord, and that can lead to permanent injury as a result of swelling and ischemia of the cord. So hopefully it won't. Hopefully we can keep the swelling down in that area, keep it immobilized until the point in time where the swelling goes down and we don't get the ischemia part. Laceration is a cut or tear of the cord, and that results in permanent loss of function. Transection is rare. That will be the result of severe injury, and it's cutting the cord in two. I mean, there's not much you can do with that when it's completely transected. Hemorrhage around the cord can compress the cord and lead to ischemia. So this doesn't even have to be a spinal cord injury as such. It could be that we have a considerable amount of hemorrhage that's coming from somewhere else. So maybe we have hemorrhage that's coming from internal injuries in the abdomen, for example. This usually results in temporary dysfunction, so just a matter of getting rid of that blood out of the area and taking the pressure off of the cord. Hopefully the body will reabsorb it in many cases, or if it's a large hemorrhage, hopefully that's something we can evacuate. Vascular disruption. So this is a vascular disruption of the cord itself. So the cord itself is not getting the blood flow that it needs, and just like any other part of the body, it's going to become ischemic, injured, and necrotic, and then we're going to have disruption of the normal function. So on assessment, we want to be looking at our hemodynamics. Remember that, again, our hemodynamics, if we're not having enough blood flow to that area, the patient's going to have additional secondary injury to the spine. Hemodynamically, too, we want to be looking for neurogenic shock, because neurogenic shock can mask that the patient's got hypovolemia. And in fact, that we'd want to be doing some volume resuscitation. X-ray, CT scan, MRI, CTA in some cases. So typically our CT and MRIs are going to give us some really good information about what's going on with that spinal cord. Most common complications include sepsis and pneumonia. So our infections, the patient's not taking deep breaths, the patient's not moving around. The patient could develop ARDS as a result of multiple trauma. Treatment, we want to prevent further injuries. So whatever injury has occurred, we don't want it to become any more than it is. Maintain our cardiovascular and respiratory function. Again, if this is a high cervical spine injury, we can be losing both cardiovascular and respiratory function. Cervical and lumbar braces may be necessary for those type of injuries. Non-steroidal anti-inflammatories in some cases, although they will, in most cases, interfere with the healing process of the bone. Analgesics will be necessary. Muscle relaxers. Again, the spinal cord is going to innervate the muscles, and it's going to cause muscular contraction in an attempt to try to stabilize that area. If the patient is having lots of muscle contraction, those muscle contractions may be causing more pressure on that spine and therefore leading to having more permanent dysfunction. So we want to make sure that the patient is fairly comfortable with muscle relaxers, analgesics, so that we're not getting a lot of secondary damage occurring as a result of those muscle spasms. Ice usually is recommended initially. Heat may be helpful later on to help to loosen up those muscles, and then progressive exercise. Keep in mind that the sympathetic system and parasympathetic system come out of the spinal cord in different places. So the parts that are listed here in blue are our parasympathetic. The parts that are in red are our sympathetic. Notice that there's quite a few organ systems that are innervated by both. However, when you take a look at these different areas and you see the sympathetic and parasympathetic, we move down into the lower part of the spinal cord, into the lumbar and sacral area here. When you look at those areas and you notice that we have sympathetic stimulation, for example, of the gut, and we don't have parasympathetic stimulation if we lose our spinal cord. So we could have unbalanced sympathetic stimulation if we have a spinal cord lesion below about T6. So we're cutting off, see that bottom parasympathetic part, and we're only having the vagus nerve, which is only innervating the heart and the thyroid, etc. So therefore, if we have an injury that's up in the cervical spine, we could end up having only sympathetic stimulation, and that's what leads to the patient developing a real hypertensive crisis. So next up, the AACN wants us to know about meningitis. Meningitis is an infection of the brain tissue itself. And if you notice with the picture here, you can see that on the left-hand side here, we have a normal-looking brain. And on the right-hand side here, you can see that we have infected cerebrospinal fluid. As a result, we'll get infected and swollen brain tissue. So that infected and swollen brain tissue is going to be very irritated. Not only that, but we're going to start to develop some fluid, and that fluid is going to start to cause cerebral edema and compress the brain. Some of the organisms that cause meningitis are listed here. Risk factors include immunocompromise, neurosurgery, facial fractures, basal skull fracture, and CSF leak. we expect to see a headache. So the common things we associate with meningitis is headache and neck rigidity. Well, if your patient is unconscious and on a ventilator, then how are you going to check for neck rigidities? Okay, so we may not be able to test that, but we could be testing and looking for an elevation in white count that is associated with a change in mental status. Now, if your patient is unconscious and on a ventilator, the first thing we're going to see that tells us about cerebral edema is an increase in our systolic blood pressure. So be looking for that increase in white count or increase in fever associated with an increase in systolic blood pressure, and that can be giving you an early sign that we're developing cerebral edema as a result of developing meningitis. Encephalitis is another type of infection that we need to be concerned about, usually affecting the frontal and temporal lobes. HSV is the most common type. It can be a new infection or a reactivation of the virus. Symptom-wise, neurologic changes, headaches, seizures, fever, and we're going to diagnose it with our MRI, CT scan, and again, looking at the CSF. Treatment will be antivirals and steroids. So we want to, and one thing here to note about the difference between antivirals and antimicrobials. When we are treating a bacterial infection with antimicrobials, what we'll be using is an antibiotic that is going to kill that bacteria. It does something to the replication cycle of the bacteria so the bacteria can't continue to live. However, with antivirals, we don't have the same kind of medication. What happens instead with antivirals is we change the way that they replicate so that they die. So that when they try to replicate, they will die. So it's not directly killing the virus. Instead, our own immune system will do that. What we're trying to do with an antiviral is slow it down enough that our immune system can catch up. So antivirals help, but they're not killing the virus. Our own immune system has to do that. Well, thank you for joining me for part 1 of Neurological of our CCRN review. Let's keep going. Let's move on to part 2.